Good morning. At the outset, I would like to thank Dr. Arup for giving me the opportunity to participate in this CME, in this instruction course. Toric IOL is the best way of correcting corneal astigmatism, even though there are other ways of doing it, but whenever we have to implant a lens, probably the Toric IOL is the best, especially when the patient comes with cataract, and this is highly satisfying. All we have to do is to develop the proper concept to correct the corneal astigmatism. In my practice, I take one diopter as the cutoff point. Anything more than one diopter, I go ahead with the thing. But there are a lot of people who are doing with minus 0.75 diopters also. IOL power calculation, which has already been dealt nicely in the first talk, is of paramount importance because patient comes to us for visual recovery, and the visual recovery mainly depends on this. Whatever method works well in our hand for regular cataract surgery is okay. A lot of newer IOL power calculations formulae are available, but as Dr. Ramesh said, the Barrett's Toric IOL power calculation is the best. Since we are going to mainly focus on corneal astigmatism, keratometry plays a very important role, even though we can measure central keratometry value in many ways. But what I feel is, whatever way of measuring keratometry for corneal power for IOL power calculation in our routine practice is okay. I prefer keratometry from IOL Master 700, even though I do not have any financial interest in this, but I make sure that it correlates well with the other keratometry values from the autorefractometer and topography. And then already has been dealt with this particular topic. We will have to stabilize the ocular surface. We can get on ocular surface analyzer. In case it is axis deficiency, it has to be rectified. In case if it is meibomian gland dysfunction, then probably one can go ahead with the various ways of treating it, including IPL or maybe Thermiflow. I feel topography is a must because now topography is available with everybody. It's a must for various reasons. One is to know if it correlates with other K values and axis determination, and to see if cornea is regular, set to rule out keratoconus or pellucid marginal degeneration, to see if corneal status is regularized following any of the corneal surgeries, that including pterygium surgery. We will see an example later. And then to know if patient has already undergone laser vision correction earlier and doesn't give the history. This is one example where a person was counseled properly, and then he underwent toric IOL implantation, but regular lens implantation. To our surprise, patient later on was not happy, and then when we did topography, it was an aborted case of keratoconus. So probably if I had done this earlier, I could have easily counseled the patient in a better way. That's why topography is important. Second thing is, this particular patient with the pterygium and cataract underwent pterygium, and then after 1 month, as the usual practice, underwent a toric multifocal IOL implantation. But to my surprise, the astigmatism went on increasing up to almost 16 weeks before it became stable. So the model here is we should always wait for topographic stability in these cases. It is not just not to go by the time. And then Baylis nomogram, of course, Dr. Douglas Cock is here, and he and his team, they have given this particular thing where the topography can give us posterior corneal astigmatism. In case if it is anterior, with the rule astigmatism, jump up by 0.7 diopters. In case if it is against the rule astigmatism, jump down by 0.7 diopters. Next important thing is reference marking. There are various ways. Manually, you can do it in the patient, the sitting position. Best way is to do on a slit lamp. There are so many markerless things available now in the form of Varian or Callisto. And axis marking can also be done with the Mendes marker, which is normally being done. Any rotation more than 10 degrees becomes clinically significant and requires the rotation if patient complains. As you see here, the reference marks are way ahead, they do not match with the 0 and 180 degree. I think so this is with the eye trace. So one is above, one is below. So using Zaldivar's caliper software that is available, incorporated in this, tells us as to how much, keeping the same reference markers, we can move the, we can rotate the lens so that we get perfect thing. Optivia refractive analysis, that is ORA system, the intraoperative barometer enhances the toric IOL surgery by providing real-time measurements and calculations to optimize IOL power and axis placement, leading to improved refractive outcomes. ORA tells us how much to rotate intraoperatively to get proper refractive correction. But all said and done, this also has got a lot of limitations and drawbacks, and it may not be affordable to every cataract surgeon. Then when it comes to the surgery, to give proper outcomes, one is the incision site. Even though we plan it at 0 degrees, sometimes it may not be possible because of the rotation, the torsional rotation of the eye. And then in case if a surgeon is not comfortable in that particular position, it's always better to choose an area where he is comfortable, probably a little on either side of the 0 degrees. Then rexis should be central, circular, and at least 5 to 5.5 millimeters to avoid the decentration of the lens in future, because the fibrosis can be influenced. And then in case if we use viscoelastic substance for implanting the lens, maybe we can stop short about 10 to 20 degrees and then remove the viscoelastic, especially under the IOL, so that the lens doesn't rotate, and then make the final correction. Best thing would be to do a under BSS implantation. Then the third thing is to prevent extra, overheating the antechamber, because a layer of fluid can go underneath the IOL and can destabilize. And then post-op management, first 1 hour is where the maximum rotation is supposed to occur in first 1 hour. That's called golden hour. So better to see the patient after 1 hour and ask the patient to lie down supine. I don't know to what extent it helps, but this is what has been advised. And as per the post-op management is as per any other cataract removal. And then, of course, we have to keep in mind the patient's perspective. Patient has come to us for good vision, visual recovery. And then, in my opinion, toric IOL practice is far more forgiving. And a well-planned toric IOL surgery should give a satisfactory result to both the surgeon and the patient, and maybe near perfect, picture perfect vision. Thank you very much for your patient listening.
Yeah. So thanks a lot, Satya, for your very informative presentation. As Dr. Anand takes stage to get your slides are okay worked out? Yeah. So Anand will be talking to us on recent developments in post-refractive surgery situations. Any questions for Satyamurthy? See, for example, pterygium patients after pterygium surgery, there's so much of irregular astigmatism. I have never thought about doing a multifocal lenses for those situations. But so that is, I think, one thing that is my experience. I thought I'd like to share with you.
Correct, sir. No, but it's not an absolute contraindication.
Yeah, absolutely. Yeah. But generally,
for the stability of the cornea, topographic stability, probably.
So one more question to you, sir. Sir. Yeah. You told that compare the keratometry with different instruments, but different instruments will give different readings. For example, autoref measures at 3 to 3.5 mm. If you take the IOL Master 700, it measures 1.5, 2.5, and 3.5, and takes the average of that. So you cannot compare the keratometry. If you take, for example, the Varion, it takes central 1.2. So basically what I personally feel is, SIM-K, what we take from topography, is for just the axis alignment, for axis reason, not for the keratometry purpose.
No, that's fine. I told you in the very beginning that IOL power calculation includes keratometry also. Whatever you are used to, probably that's the best way. It may be not necessarily a topography thing, it can be autokeratometry also. Whatever that works very well in your practice, yes.
So thanks a lot. I think now we'll move on to, I think there's one question, there's the last question, and then we'll move on to Anand.
With respect to the golden hour you mentioned, what are the reasons for the IOL rotation during that hour, sir?
Pardon me, sir. Come again.
With respect to the golden hour that you mentioned, what are the reasons for the IOL rotation in that hour?
No, there are a lot of factors, modifiable as well as non-modifiable. Few things like visco, if you don't remove properly underneath the lens, or maybe you overhydrate, These are modifiable, and then you make a large axis, which again precludes, and then the haptic design also matters. But non-modifiable things like a large capsular bag, a high myope, select the large anti-segment, maybe something which you really can't help. But I mean, this is what most of the cases, 95% of the cases, it will not rotate.
Yeah.
Thank you, sir.
So